In the first video, we looked at the symptoms of bladder cancer, the diagnostic test used to make a diagnosis, and the grading and staging terms used to classify bladder cancer. In this next video, we'll be looking more in depth at the most common form of bladder cancer, non-muscle invasive bladder cancer, or NMIBC. We are going to discuss the treatment options open to the doctors and the experience of these treatments by bladder cancer patients. My name is Danielle, and with me today we've got consultant urological surgeon John, urology clinical nurse specialist Helen, and we've got three patients as well with us today. So we've got Alison, Barry and Elaine. So John, what is non-muscle invasive bladder cancer?
When a bladder cancer diagnosis is made, we look at the cells under the microscope and we're looking to see what layers of the bladder that they're growing into. The bladder has many layers. The deeper layers are called muscular layers, and there's surface or superficial layers as well. The way that bladder cancers have been shown to behave are different depending on what layers they grow into, and non-muscle invasive bladder cancer just means that the cancer cells are not growing into the deeper layers of the bladder.
And what treatment options are available, and how do you decide which ones to use?
I think the most important thing to say is that the treatment options are tailored both to the cancer itself, but also to the patient. So what we'll want to take into account as a team looking after patients is, one, how fit you are, okay, and also your general quality of life. And then two, we'll look at the cancer actual parameters themselves. So how aggressive is the cancer and how likely is that cancer to progress? So we talked a little bit about grade and staging in the last video, but if a cancer is low risk, then the treatment may be just watching your bladder to make sure that these growths don't come back. So that means regular flexible cystoscopies. If your bladder cancer is slightly higher in risk, we might talk about installations into the bladder. So that means that we actually use we use the term chemotherapy, okay? But what that means is that we put a small flexible tube into your bladder and we can instill a liquid solution, and that's the chemotherapy. And the purpose of that is to both kill bladder cancer cells but stop that type of cancer from coming back. Okay. And for patients who have that as a treatment, they may hear terms such as mitomycin or epirubicin, and those are types of those bladder chemotherapies that we put into the bladder. And then finally, for patients with non-muscle invasive bladder cancer that looks higher in risk, we may want to find a little bit more information out about that cancer. So as part of the treatment, we might do another operation to remove more tissue from the bladder. And then for those patients, we might talk about either we call immunotherapy into the bladder. So that means putting a solution into the bladder that affects how the cancer cells behave. And for patients who we're talking to about that, they might hear the term BCG. Alternatively, we may also talk about surgery to remove the bladder as a treatment option.
Okay, and then Helen, what is the MDT and what part does it play in all of this?
So MDT stands for multidisciplinary team, and it's a team of people who work with bladder cancer. The majority of the time you'll see the surgeon and you might see hopefully see the clinical nurse specialist, but behind that there's a whole group of people who are working to put together results and information and review everybody's case. In our institution we have a weekly large MDT meeting. There's a pathologist there who presents the results of any biopsies or tumours that have been removed from the bladder. There's a radiologist who may be looking at scans to try and correlate scans and match scans with lesions that have been removed. We've got an oncologist who deals with non-surgical treatments for bladder cancer. We've obviously got nurse specialists like myself, the urology surgical consultants, and a whole team of administrators who back up those meetings that happen every week.
So I think it'd be worth hearing from the patient's perspective. Barry, can you describe what treatments you had at this stage and how you felt about them and reacted to them?
Okay. After the cystoscopies, I had mitomycin, which is the chemo wash, followed up sometime later with more cystoscopies, and they decided to do a BCG. And then just on a watch with regular cystoscopies to see what was going on. No real side effects for me. That seems to be the norm, thankfully. Maybe a bit of tiredness after BCG, but nothing really to talk about.
Okay. And Alison, what was your experience like?
Well, I was given the treatment of BCG. I had quite a high-grade cancer. After the first round of BCG, it didn't seem to be working, but we persevered and had some more BCG, and for me it's been successful. And with the side effects, I really just felt a bit tired, symptoms of cystitis a little bit, sore, and having to go to the toilet a lot. But really it's very manageable.
Okay. And Elaine, what about you from your point of view? How did you get on with the treatments?
The treatment's fine. It's I was diagnosed 4 years ago, so I've had many rounds of BCG, which was quite regular the first 3 years, and then thankfully it actually worked and I was cancer free. So I'm now on what they call a maintenance program. So every 6 months I have 3 weeks of BCG, which is keeping the cancer at bay, regular cystoscopies. And thankfully it's working. Side effects pretty much like Alison said, very manageable, a bit flu-y like, and as time goes on, obviously my bladder's had quite a lot of intrusion, so it's a little bit more sort of irritable, but it's keeping me cancer free, so well worth it.
And then John, following these treatments, what sort of follow-up can the patient expect?
The main purpose of follow-up is to make sure that cancer cells don't come back, and also if they do come back, that we catch them at an early enough stage to be able to do something about them. So depending on what your risk status is when we've looked at the cancer cells under the microscope, we will usually follow you up with regular looks inside the bladder as the mainstay of your follow-up. So that means regular flexible cystoscopy. Now the period between the flexible cystoscopies is down to our suspicion with respect to how likely the cells are to come back and how quickly they might come back. For a group of patients with slightly more aggressive disease, that first check inside the bladder might be done under a general anaesthetic. So it's important just to be aware of that.
Okay. And then we heard a little bit from you, Elaine, about you on the maintenance programme and that sort of ongoing follow-up experience. What about you, Alison and Barry?
The follow-up experience for me, until we got to the decision about removal, was just flexible cystoscopies at regular intervals to make sure that everything was status quo.
What are you?
Because my BCG seems to have worked, I'm on a programme of 3 monthly checks for 2 years, and I'm halfway through that now. And after that, I believe I'll be on 6 monthly check. And I just find that really reassuring to know that someone's keeping an eye on my bladder and what's going on.
Thanks, everyone. So in this video, we have looked in some detail at non-muscle invasive bladder cancer. And in our next video, we will look at muscle invasive bladder cancer, or MIBC.